Dr. Parry is on with us or not yet?
I believe he is on.
We don't see his.
Do you know what he be? Do you know what he be under?
Yeah, we have to be smart start to try our parents. You can't go there.
Oh, Dr. Parry, there you are. Oh, that's Dick Fisher.
Yeah.
I had to step out. We got our water heater being replaced, so I had to go out there. I wanted to thank anybody who made contributions to the Alzheimer's Association. The Fairfield County Walk has generated so far $262,000. We're open for contributions through December 15th. So if you don't remember how to give contributions, you can email me and I'll get back to you. And I thank a couple people who did that so far. Thank you.
You have something to eat with you, Mary?
Dr. Parry just joined us.
I don't know, there's some Christine there on the top.
All right,
breadstick.
Dr. Parry, I just unmuted you, so we should be able to hear you now.
Yes, good. I was going to do that, but I see it happened all by itself.
Hi, Doctor. Good. Welcome. Okay, before we bring Dr. Parry on, is there any other items of discussion that you guys may want to bring up? Okay. Well, without Dr. Parry, are you ready?
Can you see my screen?
Yes.
Yes, we can.
All right.
There is a screen.
Okay.
This is a pitch or graphic from Dr.
Yes.
All right. Today our speaker, as we indicated before, is Dr. Michael Parry. Dr. Parry is the Chief of Infectious Diseases at the Stamford Hospital and Stamford Health Organization. He's been in practice for over 50 years in medicine, and he medical school, graduated Columbia University College of Physicians and Surgeons as well. He did his residency at Columbia and at the University of California in San Francisco. And he did his fellowship at Columbia University also. He's board certified in infectious diseases and internal medicine. And among the things that Dr. Parry gets into, if you recall, when he spoke to us a few years ago, he helped design the precautionary measures in the new hospital, which proved to be very effective. He's been very active with the COVID pandemic, but aside from that, he's involved, and his department is involved in all types of infectious diseases, bacteriological, including Dr. necrotizing fasciitis. Your reputation precedes you, Doctor, and we welcome you, especially now with the situation going on. So, Doctor, the floor is yours. Thank you for coming.
Thank you very much. Pleasure to join you. And it's been a tumultuous year, I guess I could say. We were crazy busy, and I'll show you what happened in March, April, and May. And then we had a very optimistic summer. And now we're on the rise again. So I hope we don't repeat March, April, and May, but we are certainly going to see more COVID-19 than we did in the summer. And we hope we've learned something from our experience in April and May, and that we will have a smoother winter, but that remains to be seen. So we use the Johns Hopkins website as a good reference point because they update the statistics on a daily basis. And you can see this picture from the website, which I took yesterday, showing the global picture, 44 million cases globally, and over 1.1 million deaths globally. The map in the middle is the US, and it depicts the density of cases cumulatively since the beginning of the pandemic. As you know, the US leads the world in number of cases, over 8 million cases, almost 9 million cases. India is second, as you can see from the tabulation on the left-hand side of this website page. The graph on the lower right, I think, is particularly alarming because you can see that there is no evidence that the pandemic is slowing down. These bars, the orange bars in that graph, represent the number of daily cases. And you can see that although the curve has some irregularities, it's inexorably up and not plateauing at this point in time. So I think the world is still in for a long course of COVID-19, and certainly that's true for the US as well. This is actually also from the same website, and it just compares the countries, the US in green, India in orange, Brazil in the pink curve that's kind of coming down. You can see that the US curve in green has several different waves. A lot of this is related to regional concentrations of infections, not the country as a whole. And the death rate is also interesting because the US has a higher death rate than many other countries. You can see it on this graph here. Peru, Brazil, Spain, Mexico, and then the US. Many countries, including those with a lot of poverty and variable medical care, have much lower death rates. But there are some specific reasons for this. There's underreporting from many countries. Since we know that people under the age of 50 do very well with COVID-19, even without medical care, they are not going to die. So countries with a median low age, like India and Kenya, and other African countries that have a low median age actually will do very well and have a low death rate. In the US, where our population has a lot of obesity, and that's a very big risk factor for bad outcomes with COVID-19. Higher age is obviously important also. In some countries, there's a lot of cultural compliance with mask wearing. Mask wearing has been common in the population for many, many years. They do what they're told, and there's lots of not a lot of non-compliance, which I think is not typical of the U.S., but is typical of some cultures like Asian. And in China, if they want to lock down the country, it's said and done instantaneously. Not so easy to do in a country like ours. There's also some suggestion that other viral infections that are seen in some areas of the world, like dengue, other coronaviruses, are more prevalent, and that may give some immunity to the population as well. So death rates are not strictly comparable from country to country in the global data set. And this is a map that comes from the New York Times, which actually has a very excellent database and keeps up to date on a daily basis also, and that's readily accessible to most of us. You can see that here the new deaths reported in the US was very high back in April and May when we didn't know much about COVID-19. This peak here was the disease in the Northeast. There wasn't much in the rest of the country. Death rate was high. We've learned a lot since then. The death rate has come down, even though the peak of occurrences in the U.S. has continued to rise. This peak here in July and August was a lot of disease in the south and the far west. That also seemed to improve. And now nationally, everybody is increasing in COVID numbers. And actually, we are higher than we have ever been in the last couple of weeks. This is a sort of a cartoon map of the US, and it looks at individual state data to show where COVID-19 is increasing, decreasing, or unchanged. Decreasing states would be in turquoise. You don't see any of that on this map. It is all orange. Almost every state, even those with relatively low numbers, have increasing rates of COVID-19. Pretty dramatic looking map, and it's changed a lot over the last month. Even in Connecticut, all of the Northeast, all of the Midwest, all of the Far West, all these states are seeing increasing numbers of COVID-19. And there are some specific hotspots in red here, the upper Midwest, certainly. The lower Midwest and southern states, these have been hot spots for some time. Another way of looking at the distribution of cases throughout the US. The Connecticut Hospital Association keeps pretty good track of what's going on in the state. And you can see our experience reflected in this graph, which really represents the whole of the state of Connecticut. But our own experience was in April, May, and June, lots of inpatients with COVID-19. All counties in the state of Connecticut saw a lot. And then the summer months of July and August, we saw very little. Total hospital COVID-19 patients in August was only 20 or 30 across the whole state. And in the last month, we've gone up. So we're now a little over 300 inpatients throughout the state. So you can see this graph is rising, and this is a 7-day average, also rising. So we're in for perhaps a busier winter than we had hoped. The state also keeps track of different levels of activity throughout the state. You can see that in the last month, there's been a lot of activity in the New London area, in the east of Connecticut, a little bit in the Hartford area, and then Norwalk, Fairfield, and Danbury are the hot spots right now in Fairfield County. This is Stamford data, and it just shows where we have come in the last year. The green line in this graph represents influenza. And in January and February, we were in the middle of a busy influenza season, although when you look at it next to COVID, it doesn't look like it was very busy. But then we were hit dramatically in middle of March with this massive outbreak of COVID-19. And these are the number of cases of COVID or influenza that we saw on a daily basis. So in April, we were seeing over 100 cases, new cases of coronavirus infection every single day. These are not hospitalized cases. They're all cases. They would include hospitalized cases. But you can see how dramatic the numbers of cases were. And then over the May-June period, these numbers fell. And although we had very few in the hospital, we continued to see in the community 10, 15 patients every day testing positive. And we do about 2,000 to 4,000 tests a day. Inpatients, outpatients, referred from physicians' offices, walk-up patients, an emergency room. If you add all these together, we were seeing about 10 to 15 patients a day. And that was a kind of a smoldering low level throughout the summer. But you can see what's happened in the last 2 weeks. We're going up again. We're seeing 20 cases a day on average over the last week. So it's clearly picking up. I think this really puts into perspective from that 30,000 foot level how dramatic the pandemic is compared to a standard busy influenza season in green. The other thing that is worth taking away from this graph is when COVID appeared, and we started wearing masks and staying at home and doing some social distancing, and maybe businesses closed, influenza completely disappeared, as did all other respiratory illnesses. And I'll come back to this in a different graph in a few minutes, just to show you that the fact that we used masks and social distancing and better hand washing and closing businesses and not gathering so much was very effective in reducing the risk of other respiratory viral infections. Not so much for COVID, but for everything else. And we have a dashboard at Stamford Hospital, Stamford Health, that we follow every day to track what our admission rates are, discharges, death rates, our daily census. And in this dashboard, we also look at how many gowns we have, how many masks we have, what our medication supplies are, so that we can monitor and be prepared for a surge at this time of year in a much better fashion than we were in April and May. The other thing that's pretty dramatically changed in the last few months has been the distribution of cases. These are Stamford Hospital data. And if you look at May and June, the vast majority of patients were in the over 60-year age group, in the purple bars here. The numbers represent the number of cases, the percentage of cases of COVID that are less than 40 years of age. And you can see that in May and June, most people were over 60, many over 70 and 80, and very few in younger age groups. Whereas now, July, August, and September, we're seeing an equalization of case rates over all age groups. And half of all of our patients now are under age 40, with a very good prognosis, very low hospitalization rates, and relatively mild illness with a low use of ICU care. You can see how dramatically this has changed. This is not unique to Stamford. These are just our data, but it's replicated across the country. Why are we surging now again? Well, we've opened up the state. We're in phase 3, opened up businesses, retail establishments, restaurants, people are gathering together. Everything but bars and nightclubs are open. Schools are open. Sports teams are active. There's increased mobility, particularly in younger individuals. We're moving indoors as the season gets colder. All of these things increase the risk of spread of COVID-19 from one individual to another. I think also there's an element of fatigue. We've been through this horrible period in April, May, and June. We've asked everybody to wear masks all the time, and people are just getting a little bit tired of doing that. So we see mask fatigue and distancing fatigue. People are getting together. They're having parties. They're not wearing masks as much as they're doing. They're having family gatherings, going out to restaurants. And I think the discipline that we were able to achieve in April, May, and June has just fallen off a little bit. And that's partly contributing to the surge. There's also some evidence that the virus has changed a little bit. Not enough to be like influenza where it's a dramatically different strain, but perhaps it's a little bit more contagious. Perhaps it's a little less deadly. And certainly we've learned that a lot of people that have COVID-19, this coronavirus infection, have no symptoms whatsoever. And yet they are able to spread the virus just as easily as somebody who is very sick and in the hospital. So this asymptomatic, the silent spreader, I think, is a very important component of the explanation as to why we are surging at this point in time. And as we surge, we're going to be shifting under state guidance from a yellow zone of response to an orange and then a red zone, where we will have to be more restrictive about the kind of activities we do, the kind of businesses that are open, the amount of work we do from home. And this is posted on the State of Connecticut Department of Health website. So I think a useful reference as to where we need to be depending upon the amount of disease we're seeing in the community. So testing has become a big a big item in the news, and I think it's worthwhile spending a little bit of time on testing, on what is testing all about and why is it important. This is a little bit of a complicated graph, but I think it's worthwhile walking through so that we all understand a little bit more about testing and where it's helpful and where it's not. There are three major tests that you can see that I've depicted on this slide: the PCR test, the antigen test, and the antibody test. And all three of these are commercially available. They all have federal emergency use authorization, which is a little different than FDA approval. The FDA says these tests look okay. They perform the way they are designed to perform, but this does not require proof of effective testing. It just requires proof that they are manufactured by good standards, but not that they are as valuable as they would like to claim they are in the community. So when somebody gets infected with the virus, this SARS-CoV-2 virus, coronavirus, there's an incubation period that varies from 2 days to 14 days, but averages about 5 to 7 days. The first few days, the patient has no symptoms and is not contagious. By day 5 or 7, the patient is contagious, but no symptoms. At this point, the virus can be detected in the nose, in the throat, in saliva, and in an area we call the nasopharynx, which is way in the back of the nose. And at that time, the PCR test is positive. The PCR test is a very sensitive test and will be positive early in the course of the illness, before the patient actually develops symptoms. As the illness progresses, many patients will become symptomatic. Some will remain free of symptoms. And at that point, a test called the antigen test will become positive. This test picks up proteins that the virus makes, and it correlates with high levels of virus, intact virus, and is a representation pretty well of the patient being contagious. Certainly the patient is contagious before that test is positive, but at this point in time, I think the patient is considered most contagious. This test will become negative pretty quickly. By 10 to 14 days, this test is negative, but the PCR will remain positive, as depicted in the blue line, and it'll actually remain positive for weeks to even months after the patient has begun to be sick. As at this time, the PCR test may not really represent live virus and doesn't necessarily mean the patient is contagious. Based upon viral culture and antigen tests, we think that by 14 days, most patients, even if this PCR test remains positive, most patients are no longer contagious. And we would take them out of isolation if they're in the hospital. We extend that period to 21 days if somebody is very immune suppressed, if they have cancer, if they have a transplant, if they have HIV infection. We sometimes extend that period of isolation for 21 days because they might be contagious for a longer period of time. At about 10 to 14 days, another test is available, which is called the antibody test, and this looks for the immune response. It will stay positive for months to years in some patients. It represents immunity in some, but we're not sure that that immunity is long-lasting. It's not useful for diagnosing anybody with acute infection. For that, we rely on the PCR test as the gold standard. The antigen test may be, but not the antibody test. This is sort of after the fact. It shows that maybe you've had it, but not when you have it. So that's what this slide really tries to show. So just a couple more points. First, about the PCR test. It detects RNA of the virus, not specifically live virus. So that's why it's positive late, even when the patient's not infectious, because the virus seems to persist in tissue and pieces are detectable as RNA for months. So we do get these false positives, particularly a long time after the patient has resolved. False negatives can occur, but it tends to be very sensitive and very specific, so that we don't see many false negatives. We do see some false positives, but that's related to the fact that the virus is gone, the RNA persists. I talked about isolation, and we do recommend isolation, certainly for the first 14 days of illness. Just to give you some reference points, we check the results of our testing weekly, and our prevalence of positive PCR tests last week was a little over 4%. In the month of August and September, we were less than 1%. So the prevalence of active infection, potentially contagious, in the community is 4 to 5%. That's 1 in 20 people. Half of these will be asymptomatic. So you really never know who is infected. That's why the concept of universal masking, being careful about hand washing and social distancing, is so important, because patients are just not always symptomatic. Our ED prevalence rate last week was 13%. Now, these are people coming in with complaints. They may have a cough, fever. These are active COVID patients. So you can understand why for random testing, the results average 4%. But in people coming in with illness, sick enough to come to the emergency room, the rate of infection is much higher, and obviously is indicative of the surge that we're seeing across the state of Connecticut. And frankly, based on that previous graph, it's really true across the country. We screen everybody who is admitted to the hospital. We screen everybody who's having a procedure, be it a colonoscopy or surgery. We screen women coming in for delivery, so we know who's positive and who's not. These patients have no symptoms, and they are positive about 1 to 2% of the time. So we do pick up some positive patients, completely asymptomatic, coming in for unrelated conditions. And in the state as a whole, they reported last week that the state average rate is about 4%, which is exactly what we're seeing in Stamford at this point in time. Just to mention the antigen test, again, this got notoriety because it's the test that the White House has been using. It's a rapid, inexpensive, uncomplicated test that is easy to do and doesn't require complicated equipment. Unfortunately, it's insensitive. It doesn't pick up infection early. It doesn't pick up infection late. There are lots of false negatives and false positives. It is not a test that at Stamford Hospital we are currently doing, because we just don't have faith in it. The gold standard remains the PCR test. And if you've got PCR available, it is also rapid. It is a little bit more complex, but that is our preferred test for diagnosing acute infection, and at this time, not the antigen test. We might use it as a backup if we run out of PCR tests, and the testing materials are often in short supply. So we actually have 4 different types of PCRs, different brands of PCRs, because we don't want to run out. We've had to kind of duplicate testing because we need to have the security of being able to test when it's absolutely necessary. The antibody test I mentioned, it's a blood test. It's not a swab, because this detects antibodies. It doesn't detect virus or viral proteins in secretions. Those secretions could be nasal, throat, or saliva even. But this is a blood test. It looks for antibodies. It's positive at 14 days or later. It's useful to corroborate a diagnosis. It's useful to corroborate groups of patients, the prevalence of infection in those groups, like nursing home patients. It's not useful, as I said, for diagnosing acute infection. And the prevalence of tests, positive tests in our community, 4 months ago was 7%. We're now close to 15%, which tells us that 15% of the people in Stamford that get tested for this antibody test are positive and have had COVID-19. That's a lot of people. But we'll touch on this in a few minutes when we talk about the immunity that you need in the population to create what we call herd immunity. It's obviously much higher than 15%. But that's where the community sits now. 15% of the community of Stamford has already been infected with COVID-19. And of course, most of those people have recovered, but some have died. What have we learned about COVID symptoms? We've learned that, as I mentioned before, that 40% of patients with COVID-19 are completely asymptomatic. They may never develop symptoms, and yet they're capable of transmitting infection. Then there are people who are going to get symptomatic, but just like influenza can be contagious before symptoms begin, we call this pre-symptomatic. And certainly for COVID-19, we know that that's true for a period of probably 2 days or so prior to the onset of symptoms. So you have not just asymptomatic people, you have people who are going to get symptomatic but are not yet symptomatic who can transmit the virus. It makes it very difficult, obviously, to control the spread. The remaining people who get symptomatic, the vast majority have mild illness, particularly young people under the age of 40. The illnesses are generally very mild, don't need to be hospitalized, don't even need to come to the emergency room, and they present just like a mild case of influenza with cough, dry cough, muscle aches, headache, fever, chills, sometimes shortness of breath. The only thing that reliably distinguishes COVID-19 from influenza is this characteristic loss of taste and smell in COVID-19, which we do not see in influenza. On occasion, it is seen with other respiratory viral infections, but is characteristic of the coronavirus. Aside from that, the manifestations of the two are very, very similar. And it's going to be a difficult season in distinguishing one from another, which is why we're often testing for influenza and COVID-19 at the same time in the same patient because of very similar complaints. The other things we've learned in terms of COVID-19 symptoms is people who recover tend to have a very prolonged recovery period. Usually with the flu, you're sick for a week and then you get over it and you're back to baseline in a couple of weeks. But people with COVID-19 often are sick for months with fatigue, aching, confusion, shortness of breath, and chest pain. This has been referred to in the literature as long COVID. And it's a real entity. We don't know fully what causes it. It's probably related to the immune response in some way. Not everybody has this, but it's common enough to be a concern and something that we need to be aware of and explain and understand as patients are seen in our practices after having recovered from the acute episode, but continuing to be disabled by these other chronic conditions. We've learned that the nervous system and the kidney are commonly involved in COVID-19. It's not just a respiratory infection. It indeed involves many other organs, particularly the brain, the kidney, and the heart. Cardiac studies show that 70% of patients with COVID-19 have inflammation of the heart muscle, as judged by echocardiogram, by measuring enzymes that are in the blood that represent inflammation of the heart muscle. This can lead to heart failure, independent of the lung involvement from COVID-19, and obviously needs close follow-up in patients that have more severe cardiac involvement than others. There's also a very interesting multi-system inflammatory syndrome that's been described in kids. In March and April, we didn't think kids were infected at all. Then we learned that many of them were infected, but were symptom-free. And now we've learned that in children, there's a late infection, a late inflammatory process that is an immune response that manifests itself by fever, rash, gastrointestinal and blood abnormalities, and patients can be very sick with this, even manifesting as shock. Fortunately, because these are young people, and because this is an inflammatory process more than an infection, These kids do generally very well. But it's just another of the protean manifestations of COVID-19. It's a much more complicated process than we've become used to with seasonal influenza. In terms of treatment of patients, we don't have anything that's great. We have this sort of multi-pronged approach to the management of sick patients with COVID-19 who need to be hospitalized. We give them steroids, dexamethasone, which has been shown to reduce the risk of mortality because it reduces the inflammation associated with the late manifestations of infection. Remdesivir, which is an antiviral drug, which in some patients seems to help, but a recent WHO study refuted the fact that remdesivir does anything. So if it helps, it's a small help. We've used convalescent plasma as a way of helping the patients over the acute episode by providing them antibodies, some passive immunity to help them recover. We feel that all three of these together are additive and are helpful, and we do this pretty consistently with anybody who is sick enough to come in the hospital, has low oxygen levels, and infiltrates on chest x-ray and persistent fever. There are some investigational treatments, monoclonal antibody, which you've heard about, Regeneron, that the president received. There's a similar compound produced by Lilly. Lilly just abandoned their study showing that these monoclonal antibodies in their hands were not useful. So this is a big question mark. Do these really help or do they not? That's about all we have at this point. Nothing very dramatic. Somewhat helpful perhaps for people who are sick enough to be hospitalized. But of course, there are other things that we do to support patients who are sick. We've learned better ventilation techniques. We've learned to give high flow oxygen, which is helpful in avoiding intubation. We've learned that clotting is a common problem in COVID patients. And so we have a standardized anticoagulation regimen for these patients. So all in all, the prognosis for people who are hospitalized with COVID-19 is better than it used to be, but not because we have a magic bullet. We've just learned to do a lot of little things better. We've also learned that the transmissibility of this disease, and it is quite a contagious disease, can be prevented in large part by using safe personal protective equipment. We know that in April and May, we had real shortages of this. We had shortages of masks, we had shortages of gowns, we had shortages of eye protection, and we had to extend the use of eye protection, face shields for a week. People used to wear the same mask for days at a time because we didn't have excess numbers. We've all learned that we need to wear a mask at all times in the hospital. We have been aggressive about stockpiling over the last 5 months so that now we have lots of masks, lots of gowns, lots of face shields, and we've liberalized the use of these so that we can all get new masks every day, new gowns when we need them, new face shields when we need them. We're pretty well situated from a PPE stocking perspective. But of course, this is a never-ending proposition. We have to continue to source PPE on a constant basis. And as part of our dashboard, we look at this every day, every week to make sure that we have lots of supplies to protect our patients and to protect our staff, keep us safe. Certainly, many of our staff did get COVID-19 in the beginning when we didn't understand that we needed eye protection, face protection. We needed to use masks universally at all times. A lot of our staff infections were actually acquired in the community because obviously we live in the community as well as work in the hospital. So we are at risk not only here, but also at home. Most of our staff infections actually were related to community exposure and not work exposure. And what's interesting is that the staff here at the hospital that actually came down with COVID were not the frontline intensivists and ICU nurses that were taking care of all the COVID patients, they were people in support departments that were more exposed in the community, not so much in the hospital, which gave us a lot of comfort that we actually had good policies in place to protect our staff in a hospital setting. And the one thing that we saw, and I alluded to this earlier, is the minute we started to wear masks and do social distancing and better hand hygiene, we saw that all other respiratory viral infections completely disappeared from the community, from the testing that we did. This graph shows all of our COVID cases by positive tests from the beginning of March through the end of July. And if we look back at the last 4 years in this red curve here, it shows that we were seeing respiratory viral infections all spring long through into August. This is the cumulative numbers over the past 4 years. We saw coronaviruses, we saw metapneumoviruses, rhinoviruses, influenza viruses, respiratory syncytial viruses. All these viruses produce respiratory illnesses during the winter, spring, and early summer. And you can see this was our experience for the last 4 years. But the minute COVID came and we started to wear masks, all of our respiratory viral infections disappeared. And for weeks, we would see zero influenza, zero of anything else. And it's because masks, social distancing, hand hygiene protects us very well against many of these respiratory viruses. COVID is more difficult because it's more contagious and more durable. And many people are asymptomatic, so you don't know who's infected. So that's why the COVID curve isn't plummeting, unlike these other viral infections that can be much more reliably protected against by wearing PPE. I talked about this before. This is the number of people who've been infected in Stamford based on our antibody tests. It's gone from 7% to 15% over the last 6 months here. So this 15% represents the number of individuals in Stamford who've been infected. So that brings us to the concept of herd immunity. And herd immunity is where we need to be to have a safe community, where we need to be to maybe relax our mask wearing, to relax our restaurant visiting, to relax all of the public health measures that we put in place. We need to get to herd immunity, and that's 65% or more. Right now, we're at 15%. We have a long way to go to get to 65%. If we're going to wait for natural infection to get us from 15 to 65%, it's going to take us years to get there. So obviously what we're interested in is developing a vaccine that will be effective, that will be accepted by the public to get us to this herd immunity threshold of 65 to 70%. This assumes to get 50% vaccine immunity assumes that 70% of the population will accept the vaccine, and the vaccine will be 70% effective. So 70 times 70 is 49. That gives us this 50% added to 15 would put us to the threshold of herd immunity. This is an unknown. We don't know how many people will be interested in getting vaccine, and we have no idea how effective the vaccine will be at this point in time. But that's the concept of herd immunity and what we need to do to create a safe community. There are hundreds of vaccine candidates in the pipeline. This is a depiction from a Nature article in September looking at the number of vaccine candidates. 200 in exploration, 87 in preclinical study. In clinical trials, phase 1, 2, 3, or 4, you've got 40 of these vaccines across the world. So there's lots of interest, lots of vaccines in trials, but probably only a handful, maybe half a dozen, will ultimately emerge as valuable. And right now there are 11 vaccines in phase 3 trials. Phase 3 trials are these randomized prospective trials where you're vaccinating the population to see if it's effective. We know that most of the vaccines that have been developed and are in trials stimulate antibody. So you can measure antibody in the blood of people who get these vaccines. Almost everybody develops antibody. But what we don't know is if those antibodies are actually protective. Will the vaccine result in an antibody that neutralizes the virus and prevent infection? And above and beyond that, will it prevent, it may prevent clinical infection. Will it prevent silent infection? Will it eliminate the asymptomatic silent spreader? So we're looking at clinical infection, and we're looking at infection that is silent and can be spread. So we need to do both. These vaccines need to do both, but we don't know yet whether they're going to do anything. There's 4 different platforms. There's the new mRNA platform, which Moderna and Pfizer are testing. 30,000 patients have been entered into these phase 3 trials of these 2 companies. 15,000 are getting vaccine, 15,000 are getting placebo, and they're blinded. So we don't know who gets which vaccine or placebo, and we're waiting to see who gets sick. And at some point, they'll break the code and decide the vaccine works or it doesn't work. There's the AstraZeneca and the Johnson & Johnson trials. These are using a vector virus, an adenovirus, which is either dead or attenuated to deliver the protein or the protein of the coronavirus to the patient. And these are also very effective in stimulating immunity, undergoing the same kind of trials with the same number of patients in the trials. There's also a protein vaccine, very much like influenza vaccine. 2 companies are vying for that. And then there's some other vaccines, including an attenuated live vaccine that's very much like FluMist. You may be familiar with FluMist. It's a nasal spray, an influenza vaccine. It's the same concept, and we don't know whether that's going to work or not. So the ball is in the air, and we'll have to wait and see where it comes down. Hopefully by the end of the year, we'll at least hear whether these vaccines prevent infection or not. One thing that gives us a lot of pause is the fact that we know that some patients can be reinfected. There's a handful of patients reported in the literature who've been infected with COVID-19 who get better, and 5 months later get reinfected with the virus. And those viruses look a little bit different. They're the same coronavirus, but they've changed a little bit. We're not sure what the prevalence of this change is and how frequently this occurs, but it does give pause to, one, the concerns about our ability to control the pandemic, and 2, the value of the vaccine. How durable will that vaccine immunity be if the virus is going to change a little bit like influenza and cause infections again in people who've already had it? So a lot of unanswered questions. We're learning a lot of things. So the CDC has a very robust vaccination plan in place. All of the states have been contacted. All of the governors of every state have created a plan. We have signed on to that plan. We will certainly be participating and vaccinating our staff. There is a complicated plan of logistics to distribute vaccine when and if they are approved under emergency use authorization by the FDA. The patients will be stratified as to risk, and those high-risk patients and high-risk individuals will be the first to be offered vaccine, and then it will be offered to a larger and larger group of patients depending upon their interest and their risk. And all of this has been planned out. So it's not an unplanned process. A lot of work is already going on and very actively going on. at the federal level, at state level, and even at our individual hospital level. So be assured there is very detailed planning and process. So as we go forward, what do we have to do to remain safe before a vaccine comes? We have to remain masked whenever we are at high risk exposed, universal masking whenever we're in close contact with anybody who might be infected. And since we don't know who's infected, that's pretty much universal. We ask all our staff at the hospital, and we do this personally, to self-screen. Do I feel well today? Do I have a temperature? Do I have a cough? In which case I need to pay special attention. Maybe I need to test. We ask people who have fever, chills, cough, shortness of breath, loss of taste and smell to stay home. Don't come to work. Call in. Tell us you're not feeling well. Maybe you need a test. Maybe you need to be examined. Maybe you need to go see your doctor or call your doctor. We focus on high-risk travel. As you know, the state has a travel advisory. We ask all of our staff every day, have you traveled to a high-risk area? Unfortunately, the separation between Connecticut as a travel place and any other area of the country as high-risk travel is beginning to blur as we see local rates beginning to rise. We need to practice frequent hand hygiene. Just as influenza, we know viruses can be deposited on the skin and transferred to your mouth or your eye or your nose, and then you get an infection. So frequent hand hygiene, whether it's an alcohol sanitizer or soap and water, very important. Social distancing. We've decided that 6 feet is sort of the break point. Outdoor is better than indoor. Environmental hygiene is important. Surfaces can be contaminated, particularly the computer keyboard that's in a common area. Handrails, doorknobs, all of these need special attention for cleaning. Testing is very important, and we talked about testing, but testing in a vacuum isn't of much value. Testing requires contact tracing, isolation, and quarantine if you've been exposed. So testing is useful, but it requires follow-up, management, tracing to see who might be infected, quarantine of those who might be incubating, and isolation of people who are already infected so that others don't get infected. And then travel limitations. We do need to be careful about where we're traveling, particularly to high-risk areas. We talked about Stamford being 4% positive, but some areas of the country are 20% positive tests, 30% positive tests. Those are not areas that you want to be traveling to. And if you do travel, you need to realize that the governor has in place a travel advisory. If you travel to one of these high-risk states or high-risk countries for more than 24 hours, you need to quarantine when you return for 14 days. That 14 days is the incubation period. There is a testing alternative. If you come back from one of these areas, you can be tested. If your test is negative, then you don't have to quarantine. But you need to realize that that test is only good on the day that it's done. You can test today, but if you're in the incubation period, you might be positive in 3 days. So that test is only good for today. You still need to be careful. You may still need to quarantine if you had any high-risk exposure. These are the high-risk states in the latest map. As you can see, there isn't much of the country that's low risk. And relatively speaking, Connecticut still remains low risk, even though we're beginning to see a surge. And if you look at the CDC map, which is at the lower right-hand corner of this slide, you can see that the entire world is considered high risk. The only safe areas for travel would be Greenland and Antarctica. And certainly travel to those areas would be considered low risk. The rest of the world is high risk, just as much of the country remains high risk. So I hope I've given you a sort of a cross-section of where we were in April and May in the Northeast, where we are today, a little bit about the testing issues, which you hear constantly about. I'll reiterate that testing by itself, without the follow-ups of contact tracing and quarantine and isolation, is not terribly valuable. And finally, we all have to be very careful until we have a vaccine and we have proven that that vaccine is effective. Universally masking, continue social distancing, be careful about going out to gatherings, particularly if they are indoors. And you can stay safe, but it does require some diligence. I'm happy to answer any questions. I hope I wasn't too technical. And I think we have probably 10 or 15 minutes. So if I can hear you, I'm happy to answer.
Dr. Parry, thank you for a wonderful presentation.
Thank
Very
you.
informative, and at least, we're getting, a non-political interpretation of what's going on. We hear so much about it from the uninformed telling the uninitiated the untruths. So thank you again for giving us the lowdown, how it's affecting us. Before we open up for questions, I just want to inform everybody, I'm going to call you on a first come, first basis when you've raised your hand requesting to talk. And one question. If you have a second question after I lower your hand, go back and as if we had a regular meeting going back to the end of the line. Just one question I have before we start is you mentioned the vaccine to high risk based on our demographics of 65 to 100 years old of our group and our spouses. Would we be considered a high-risk group?
Yes, I think the first high-risk subjects, if I can use that word, I'm not sure that's the right word to use, but the first high-risk group will be your healthcare providers, because we need to keep them safe and we need to make sure that they're available to take care of you. So that's going to be the first group. And those actually can be stratified because we need to make sure that our ICU nurses, for example, are protected first. And then in the population at large, it's going to be anybody over 65 years of age. And then people with coexisting illness that would make them susceptible if they're less than 65. But age is such a predominant risk factor that's going to be the primary indicator for vaccination. And it turns out that people over age 65 respond very well by measuring antibodies to the vaccines that have been produced. So at least as far as we can measure, the over 65 group does respond well to the vaccines by blood measurements.
Okay. All right, first up is Roman.
Thank you for informative presentation, Doctor. I noticed that all of these statistics don't have China in
Yes.
on these graphs. And do we know what's the situation there? And does it matter since, neither, we know, for instance, Brazil, but there is no exchange of people between two countries. So.
No, it's a very interesting point because it all began in China. And then, of course, it's no longer just China. China is unique in that it has the ability to shut down its country, right? So you couldn't travel. The social distancing, the mask mandate, all of the things that we know really work, China could do very well. And they proved that works in a totalitarian regime like that. It's not very easy, but it's certainly much easier than it is in the rest of the world. So China really has not had a problem since the very beginning because they have exercised their authority to mandate these public health measures, and there are no options not to wear a mask, not to be socially distanced, not to stay home if you're asked to stay home. So they were able to manage it just by public health measures. And that has been our primary approach at this point.
Thank you. Stu.
Thank you, Dr. Parry. Quick question.
Yes.
Can the disease be transmitted through sexual intercourse?
There's no evidence of that. Although mucous membrane, mouth-to-mouth contact is obviously an easy way to transmit it. So it would be hard to separate out one type of contact from another. But it does actually bring up another question is, what is the risk in pregnancy and what is the risk to a newborn? And it turns out actually that there really isn't much of a problem with newborn infections, so that there may be a risk during pregnancy to the pregnant woman, but there is almost no transplacental spread. So we're not too worried about newborn outbreaks or newborn infections per se.
Larry?
Thank you for a great presentation. One of your early bar graphs showing the rate of infection by age group, I was rather surprised. The question is basically, are older people more susceptible to becoming infected than younger people? Obviously, the ramifications once you become infected are very different. But what about susceptibility?
Yeah, that's a good question. I think that there is some increase in susceptibility with age because the immune system is not as robust with age, so that small inoculums of virus may not produce infection in a younger person and may in an older person. But as you point out, it's primarily the illness that results after infection that is factored by the age. So nursing homes, for example, represent a situation of elderly people in close contact with impaired immune systems, and sometimes, depending on the nursing home, inadequate hygiene. And so that is a situation where it's a hotbed of infection, and that was responsible for much of the early mortality and morbidity, infections in nursing homes. And I think when that problem was figured out and measures were put in place to isolate, quarantine, regularly test staff and patients at nursing homes, that's made a big impact on that big purple bar, which was the peak of the over 65-year population that were infected and that suffered so badly from COVID-19.
Thank you.
Charlie Wade?
Hi, I'm Charles's wife. I wanted to know about the BCG immunity.
The question is about BCG. BCG is a vaccine that is used in many areas of the world to prevent tuberculosis. And there's a suggestion that's been made, I'm not sure that I believe it, and I'm not sure it's really been well studied, that areas of the world that seem to have low death rates from COVID-19 are the same areas of the world that have BCG vaccine programs. And that maybe the BCG vaccine has some protective effect against COVID-19. I think a lot of that's still conjecture. There are a lot of other reasons for differences in morbidity and mortality from country to country. But that has been raised as a possibility, and I'm not quite sure that I believe that that's true, but perhaps more data will come and clarify that.
Thank you.
Howie?
Doctor, excellent presentation. Thank you.
Thanks.
My question is, when do you feel it might be safe for someone our ages to be able to get on an airplane and travel to go see our kids and grandkids?
Yeah. Airplanes are a little bit of a crapshoot. Some studies show that there is very little risk on an airplane. And I think, in truth, if you're lucky enough to be on a plane and everybody is okay and nobody is coughing and sneezing, and you're in a plane where the number of people in that plane are low so that there can be some distancing, then it's pretty safe. On the other hand, if you're unlucky enough to be on a plane that's pretty crowded and there are people who are coughing and sneezing, then I think you're at high risk. So you just don't know until you get on that plane. But there's no such thing as a guaranteed safe plane ride at this time of year.
Thank you.
Yep.
Lloyd? Lloyd, you had your hand up? Unmute yourself.
Doctor, I was wondering, since virus is called unique, is it possible that it's man-made? We expect more man-made type viruses to occur in the future.
Yeah, that's a question I don't really know the answer to. I believe that these viruses certainly can originate in nature by themselves. We think that happened with MERS, the Middle Eastern Respiratory Syndrome, and with SARS, the real SARS. There's good evidence that these viruses live in nature, in bats primarily, but then can transmit to other animals and can mutate and then become contagious to humans. So whether this particular virus was man-made or man-manipulated in any way, I have no first-hand knowledge. But I think that question aside, these coronaviruses, we know, can mutate, do live in nature, and certainly can evolve from a primarily bat virus to an animal virus to a human virus, whether it's SARS, MERS, or COVID-19.
Alan Sosnowitz.
Morning, Dr. Parry.
Alan.
First of all, anybody who would lose their sense of smell and taste would certainly miss out on one of your outstanding Italian dinners. My question to you, sir. Worldwide, I did the math that 1 out of every 37.9 people die, one infected. US, it's 1 out of every 38.9 will die. Here in Connecticut, it's 1 out of 17.8 die of the virus. We have the finest hospitals in the world, and we have you. How come Connecticut is so outrageously more than twice the rest of the world?
Yeah, I don't know. I'd have to look at those numbers. There's no real reason that I know that that should be the case. So I'd have to think about that, and I have to look at those numbers. I don't really understand why that would be the case if those are correct.
Okay, thank you, Doctor.
Dick Fisher.
This is Rosalie Fisher. This is Dr. Parry. Will you take the vaccine when it is first approved, whichever company it is?
I think the answer to that is if the vaccine is a good vaccine, and we don't know that yet, if it looks like it's effective, and it's well tolerated with low side effect profile. So far, it looks like the side effects are going to be minimal. So the next question is, if that's true, is it going to be effective? And that's dependent on the results of the trials. Yes, absolutely. I would be one of the first to take it.
Thank you.
Brian McDermott.
Thank you, Doctor. That was an excellent talk. My question is, I don't really need to use a mask too often because I'm not out in with a lot of people. So if you only use a mask once or twice a week, can you reuse that mask, or is there a danger in reusing a mask and you got to wash it or just throw it in?
Well, certainly the cloth masks can be reused. they should be laundered. As long as they're 2 or 3 layers, they're thick enough there for standard use, they are fine. And certainly you can use them again. We use these surgical string masks in the hospital because we know that they are of a certain quality that does prevent those droplets spread. And we generally use these. I use this one for a day or 2, on and off. I won't use it in my office because there's nobody else in my office and the door is closed. But if I go onto the floors, to the lab, I'll wear the mask. And mask usually is effective for several days. In fact, when we didn't have enough masks, we would use these for a week, as long as they are dry, relatively clean. The dryness is important because if the masks get wet and moist, they don't filter as well. So taking them off, having a mask break, if you're in the right environment, is a good thing. Yes.
Thank you, Doctor.
Bill Johnson. Bill, unmute yourself. If your hand is up to ask a question, just unmute yourself and
I'm
save some
unmuted.
time.
I think I'm unmuted.
You're okay.
Yeah.
Yeah. Thank you, Dr. Parry. But in looking at the symptoms of COVID-19, you mentioned temperature. For a person that's in his 90s, what would be a temperature that should be worrisome?
Well, it depends on not just temperature, but what other symptoms you have as well. The fever in and of itself may or may not be present. We see COVID obviously in people who have no symptoms and no fever. So that although we take our temperature every day when we come to work and we are asked questions about travel and symptoms, those are not a guarantee that we're going to pick up COVID-19 cases, but they do a couple of things. They keep us on our toes. They make sure we're wearing a mask, and they make us think about the symptoms that we might have and might get, so that we get that early warning. But I don't think temperature in and of itself is going to be distinguishing COVID-19 from flu or from something else. We've seen lots of people with COVID-19 who are sick enough to be hospitalized who do not have fever. So it's just one element in a constellation of things that would make us concerned.
Thank you.
Doctor, we have a number of maybe 10 more questions. Do you have any time?
Yeah, I got another 10 minutes.
Okay, great. So we'll cut it off at noon. 11 or 12 at noon exactly.
Yes, that's fine.
Okay, thank you, Doc. Steve Fisher.
Oh, thank you very much for the presentation, Doctor. Question, they've got a number of different vaccines in trials and so forth. If they approve multiple vaccines which are based upon different technologies, would it be advisable, possible, or not advisable to get more than one vaccine?
That's a tough question. I don't know. Certainly, we are going to be told that if you get vaccine A as the first dose and you need 2 doses, you need to get vaccine A for your second dose. The question comes up as vaccine A is approved, first, and vaccine B comes along a month later, and vaccine C comes along a month later. Do you jump on the first vaccine, or do you wait for the second vaccine or the third vaccine? And I have no idea how to answer that question, and neither does anybody else. So I think we just have to wait and see what the data look like. Does one look like it's better than another or have a lower side effect profile than another? And I think that those are important questions that will help us answer. And the next question is, where are we with COVID-19? If we have, 30% of our population testing positive, then it's more urgent, I think, to get the vaccine out. On the other hand, if we're sort of like the summer, where we only have 1% of our tests are positive, maybe we have the luxury to sit back and say, well, let's see how the first vaccine is accepted, or maybe we'll wait for the second vaccine, particularly if that's only a one dose. I think all of those questions are very important questions, but are unanswerable at this moment.
Thank you.
Paul Rosen.
Hi, thank you. Could you talk about the value and efficiencies of pool testing and sewage effluent testing?
Yeah. Pool testing is a situation where you can take 5 individuals and you pool the samples that you've gotten from each of those 5 and do one test. And that helps to conserve your testing materials if you have a limited amount. It's very useful if you have a very low rate of infection in the population to do that, because you could, let's say you have 1 in 100 is infected. If you pooled, let's say 5, instead of doing 100 tests to pick up that one case, you could do 20 tests to pick up one pool. Then you test those 5 in that pool. So you pick up that one patient and you've only done 25 tests as opposed to doing 100 tests. So pooling testing is very helpful if you need to conserve. Unfortunately, if you have a prevalence in the population of 10%, pooling doesn't help you a whole lot because you're just double testing. It's really dependent upon having a low prevalence in the population. We are fortunate at the present time at Stamford Hospital of having enough tests not to have to pool, but we could do that if we had to. And we do have a couple of products that we use for testing that have FDA emergency authorization to do the pool testing. So that's one of our contingency plans. The question about the wastewater testing is an interesting one. Coronaviruses, unlike influenza viruses, are excreted in stool. And actually, when we had SARS in 2003 or 4, it was fecal transmission was a way of actually transmitting SARS. That's not been shown with this COVID-19, but it is excreted in stool, and therefore you can find it in sewage effluent. And people have measured the amount of virus in sewage as an indicator of the presence of coronavirus in the community. And I think I'm convinced it's useful if you're not sure you have any coronavirus in the community and your testing is negative, and then all of a sudden it's positive. And it tells you there is coronavirus in the community. Now you need to start doing clinical testing. I'm not convinced that in a community where you know you have clinical disease and you are monitoring it and testing and treating it, that knowledge about wastewater testing levels of virus are that important. But it's a research project and people are interested in it. And I know Yale has been very much involved, but I'm not really convinced that it's helpful in predicting the way you're going to deliver care, because it's just an adjunct and I'm not sure that it helps you since you're already testing patients anyway.
Thank you. Carl Bunch.
Dr. Parry, I noticed on the slide you had talking about the state's preparation for prioritizing the distribution of the vaccine.
Yes.
That you stated, or the slide stated, that the distribution would be directly from the manufacturers to
yes.
the dispensers, whereas our president continues to insist the military is going to be involved in distribution. What do we believe?
Well, I think both are in play. The Pfizer vaccine and the Moderna vaccine are unique vaccines in that they need to be stored at -70 degrees Celsius, which makes the speed of transport and delivery very, very important. So we've eliminated, or at least I say we, I'm talking about the healthcare industry from the government on down have decided that it's not useful for the vaccine to be shipped to a like the government, and then the government to distribute the vaccine. That'd be too much time wasted. But that the vaccine needs to be shipped from manufacturer to the vaccinator, the provider, in the most efficient way. So the allocation decisions will be more of a political, federal, state decision, but the distribution will be manufacturer, plant to provider, so that it can be rapidly administered. Now, the military comes into play because they are masters at delivering goods and product where it needs to be delivered in a timely fashion, because they do that to fight wars. And so they have skill set there that is going to be useful. So that's where they come into play, not more as a vehicle for distribution rather than any other element of involvement.
Jerry Kranz.
Yes, Dr. Parry. Do you have any comment on the herd immunity plan of Dr. Scott Atlas, who now seems to be the president's main consultant?
Well, I think the herd immunity data we all accept, right? It's important to have herd immunity. To not accept that is probably not to buy into the science, although the concept of herd immunity usually applies to a population that is a herd, a discrete herd without people coming and going or animals coming and going. This is a different situation. The herd is constantly fluctuating with people traveling and coming in and out of the community. So the same principles don't rigidly apply, but the concept is still there, that you want the vast majority of your community immune so they're not transmitting it to vulnerable people in the community. And the accepted number is about 65 to 70%, but in reality, it might be higher than that. It's probably not lower than that. And the only way we're really going to get to that reliable level of herd immunity is through a vaccine, unless we want to undergo 5 more years of this kind of lifestyle, which I don't think any of us want to do.
Joe, Michael?
If I'm walking in Cove Island Park with my mask down on my chin and relatively few people near me, am I reasonably safe?
You are reasonably safe, yes. Being outdoors is a huge improvement over being indoors, because air is not recirculated. Therefore, the risk of breathing in a virus is much, much less. Distancing in an outdoor environment is really a huge measure of safety. And I'm not sure that anybody has shown that the addition of a mask, if you can be outside and ensure that you are distanced, is of any value.
Thank you.
It's sort of a boots and suspenders proposition, right? You really want to maximize your safety doing both things.
Quick question. Maybe, being paranoid or not, a lot of people will be, like my wife and myself, we're in the house mostly 95% of the time with no visitors. The house is, how often do you have to wipe down and sanitize if you're the only ones in the house and you don't have any symptoms or anything like that?
Right. In that context, the rigor of sanitizing surfaces is probably not important, right? Because you're only exposed to your own germs. It's when there's others being introduced into the household that those principles need to be focused on.
Yeah, so you don't have to be that paranoid.
No, I mean, this virus is not going to, automatically, appear without being introduced into the environment.
Thank you. Bob Rosenthal, We have time for a couple more questions, and that's it.
Dr. Parry, since I guess May, socializing has been a matter of 2 or 3 couples sitting distantly outside, sharing whatever they're doing. Now it's getting cold. Is it safe to have a couple in your house? Is it safe to drive in a car with another couple if you can assume that they've been following reasonable safety procedures?
I think that's a good question because you have to rely on the fact that you have both or all have been doing the things that we've talked about in terms of public health measures. One person, the more you multiply the number of people, the greater the risk. But if everybody has been distancing, masking, hand washing, not traveling to high-risk areas or doing high-risk things, it's pretty safe, but it's probably not completely safe.
I think with that, we don't want to overstay our welcome. Sorry we couldn't get to those last few questions, but it'll be another 15 minutes. Doctor, again, thank you so much for a informative and I think at this time with the situation, a very timely presentation. And hopefully we can go on. And can we leave the door open for maybe a 6-month update?
Absolutely. I'm happy. Just reach out. I'm happy to do that.
Thank you again so much for what you are doing and what you've done. And personally, for my wife and myself, what you've done for us a year ago. So again, thank you for being with us.
Thanks very much. Enjoyed it. Thanks.
Okay. All right, gentlemen, we had a great session. We had 76 people on at one point. So stay well, stay safe, stay masked, stay washed, stay distant, and we'll see you again next week. Thank you for being with us today.
Okay.